Welcome to the Cherry Pal Podcast. This is Eric Guadera.
This is Alex Smith.
And this is Lynn Flint.
And Alex, who is our special guest today?
Today we have very special guest. We have Bernie Lowe, who is Professor Emeritus from UCSF, ran the Bioethics Program at UCSF for years, and now is president of the Greenwall Foundation, a foundation focused on bioethics research and development nationally. Welcome to the Cherry Pal Podcast, Bernie.
Hi, delighted to be here with you today. Thanks for inviting me.
And we are going to be talking with Bernie about his New England Journal of Medicine paper called Beyond Legalization, Dilemmas Physicians Confront Regarding Aid in Dying. But before we do that, we ask all of our guests, do you have a song for Alex to sing?
Alex, if you could sing something from the Beatles, how about Help?
Help! Help, I need somebody! Perfect. When I was younger, so much younger than today, I never needed anybody's help in any way. But now these days are gone, I'm not so self-assured. And now I find I've changed my mind and opened up the doors. Help me if you can, I'm feeling down. And I do appreciate your being around. Help me get my feet back on the ground. Won't you please, please help me? All right, we got Eric to join in the end there.
Yeah, but I think I was away from the microphone.
Yeah, I was just going to say,
No, I
you were
heard
like
it.
a foot away.
That cut.
That was great.
Thank you, Bernie. Thank you so much. Thank you for joining this podcast. So who wants to ask the first question?
So, May 31st, 2018, open the New England Journal. Well, I don't open New England Journals anymore. I actually get it as a table of contents. But I see an article from Bernie Lowe about dilemmas physicians confront regarding aid in dying. Before we talk about this article, Bernie, maybe you can just describe a little bit how you got interested in this subject. Like, why aid in dying, physician assistance?
Well, my interest goes back a long time before legalization. One thing I want to say is that patients thought about this. Patients wanted to talk to doctors about aid in dying and would actually request that physicians help them way before it became legal. And even when it was illegal, and now I would imagine in states where it's not legal, sometimes some physicians do agree to a patient's request. Mm-hmm. Sometimes we get so caught up with the legalization of discussions and controversies that as physicians we sometimes lose sight of the idea that legalization doesn't resolve all the ethical dilemmas. That when you've decided which way you're going to vote on a referendum, for example, thought it out, that doesn't necessarily prepare you for some of the things that will come up in your practice from patients. And how you're going to respond to those, I think, was something that I wanted to write about.
Mm-hmm. And you've been in practice as a primary care physician in San Francisco for a long time.
Long time.
Not
quite as long as the Beatles, but...
And I wonder if you've seen changes in how the physician community has responded to this issue of aid in dying over time, through the AIDS epidemic, and now with legalization. What have you seen sort of historically here in California?
Well, I think you're right, Alex. There have been changes driven by both medical occurrences, like the AIDS epidemic, and then clearly legalization. I think a lot of people have either changed their minds or become more open to differing points of view. And also, I think what's changed clearly is that patients are now much more willing, at least some patients, to talk about these issues and want to discuss them with physicians.
So I wanted to ask, as we get into this issue of dilemmas physicians confront regarding aid in dying, about first you raised this point and you alluded to it already, that often these requests are not explicit requests. So how should what clues should physicians be looking for from patients that may be requests for aid in dying that aren't explicit?
I think it's like so many things in medicine that some patients will ask what's on their mind explicitly, and others will get at it indirectly or sound out the doctor. One of the things that I've noticed myself is that people will ask a question about something they saw in the newspaper or an event like the legalization, the signing of the California bill. Or they'll tell a story about a friend or a neighbor or even a conversation they had. It may just be a question on that level, or it may be a lead into their wanting to talk about it with regard to themselves, or I've actually seen it also with regard to a family member. So I think doctors need to be open to sort of the unspoken, the hidden, the deeper meanings that may or may not be present. Mm-hmm. Sometimes a question of how do you feel about something is just a question.
And I actually have a question. I was seeing a patient this morning, believe it or not, I was doing a video palliative care consult with a woman in a nursing home who has an advanced cancer. And this was the third visit today. She was really down in the dumps. She was not feeling well. She was having a lot of challenges getting her symptoms addressed in the nursing home she's in. She's not on hospice at this point. And she talked about passively being fine if her life ended sooner. And physician aid in dying, of course, went through my mind.
No.
But I didn't say it. I just explored. I explored. And she didn't bring it up, and I didn't bring it up, and the conversation went on. But it made me think about, when do you bring it up when you're not even sure if it's on the person's mind?
Yeah. Well, I think you did the right thing, just to explore. And sometimes the things we do, just sort of open-ended questions and listening, being empathic, draws people out. Sometimes I actually will ask explicitly. You mentioned something a couple of minutes ago that I wasn't quite sure how to interpret or what you meant by it. And then ask a more direct question. When you were talking about this, were you thinking about the possibility of taking a medication to end your life? It's almost, in a way, like asking people who are depressed about whether they have thought about ending their lives by suicide, or being violent, for that matter, if they're having real anger problems. That sometimes patients will say, "Oh, no, I would never do that." But I must say, I can understand why people could do that, and that's fine.
Well, Bernie, that brings up an interesting analogy, because the old thinking around depression is, if you bring up suicidality, like, people are going to get the idea of, oh, wait, I can commit suicide. Yeah. And now we pretty much rooted out that idea that doesn't. It's actually important to bring up thoughts about suicide, and it doesn't actually make people think, oh, I want to commit suicide.
Never thought of that before.
So are we suggesting kind of the same thing here? Because I think a lot of providers think, like, oh, I don't want to bring up physician aid in dying, because then they're going to think, oh, this is a reasonable option because my providers bring it up. Is that something we should be worried about?
It is something to think about, Eric. I totally agree. And I think a lot depends on how you say it and how it comes across. I think if it's a question, is this something that you've been thinking about, then that's very different than, I want to make sure you understand that here's an option that you might want to consider. So I think it's the difference between, Lynn used the term of exploring, sort of seeing what the patient might have been thinking they haven't yet articulated, and giving the impression that you're actually suggesting or recommending something.
Well, that's interesting. Can we talk a little bit about like the ethics of it? Because if memory serves me correct, I think somebody was working on a bill in California about making sure that people knew all of their options, including physician aid in dying. I think nothing happened with that. But is there a distinction between us exploring whether or not people have thought about this and actually mentioning it as an option for around end-of-life care?
Well, okay, great question. So let me just first say, going back, I mean, there are people who believe you shouldn't bring up hospice to patients unless they ask for it, because it may be interpreted as a subtle way of telling them your time is up, given the misunderstandings about hospice. So, Eric, I think you really put your finger on an important point regarding how does what the physicians say get interpreted by the patient, and how do you frame things in a way that you make clear that you're informing people without really advocating anything. So again, I like to use the analogy. Now, maybe you all do this better than I do, but sometimes just bringing up palliative care or hospice. I have a patient now I'm trying to go into hospice discussions with, and one of the family members is really concerned that hospice means giving up, that you're signing a death warrant. But I did want to make sure that it was one of the options. And so I framed it by saying, I just want to make sure you know all the options, ranging from sending the patient to the emergency room, or this will happen, to trying to manage her at home, to trying to bring in people who can help relieve her symptoms at home. And hospice is the best way to do it. And I backed off because I knew there were concerns saying this may not be something that you want to consider, at least at this time, but I just want to let you know it's one of the options. So I think how you frame it, rather than just saying there are 5 things we can do, and number 5 is, I think it's really in the context of the relationship you have and the goals of care, and sort of what your sense of what the patient's needs and concerns are.
Have you, or would you ever do the same with physician aid in dying? Would you actually ever say, these are options and physician aid in dying is another option?
I probably wouldn't quite say it that way, but I think people frame it differently. I would say, and there's another approach, and there are some people who consider, think about, and ask for aid in dying, which means getting a prescription for a lethal dose of medicine that the patient takes when they think the time has come in their terminal illness.
All right, one last question from me, because I think Lynn has a question.
Yeah, sure.
What words should I actually use? So you wrote in this physician aid in dying, there's physician assisted death, there's physician assisted suicide, there's death with dignity. Like, how should I label this?
Yeah,
or does it matter?
Well, no, I think it does matter because people interpret terms in very different ways and react to things that may actually be misunderstanding. So, I think you've all been through we call it palliative care now because so many people have negative connotations about hospice. I tend not to use the phrase and just describe what it is. It's talking about, and in some cases, asking for and receiving a prescription for a dose of medicine that they can take to end their lives.
That's great. Like taking away the label,
that's right.
Often meaningless label.
Just saying what it is.
Right.
That's what it is.
Right. That's right.
But we can't do that as doctors. We need to actually not even label it, but
come up with an acronym.
Like
PAD.
Right.
We need to give it a name that nobody will understand.
No,
that makes us sound intelligent.
Disease.
That's why they changed it to HFpEF from whatever it was, heart CHF. I want, going back to my patient, another thing that felt like a dilemma to me in that particular scenario was that I was thinking about no matter what my own personal position is on physician aid in dying, or whatever we want to call it for the podcast, I had this sort of fear of, maybe this is because I'm a palliative care doc, I was less afraid of the emotion that was going to come and more afraid of just the sheer logistics of what I would do if this person said, yeah, that sounds like a really great option. And then I got a little stuck in my head of like, well, am I withholding this information because it's logistically difficult and I don't exactly know how to do this? And I got a little tied up in my head.
Those are really, really important questions. And hats off to you for recognizing them and being honest with yourself. So the very first thing I think is you said something regardless of your own position. And I think clearly doctors will have many doctors will have strong feelings one way or the other, supporting or opposing. And one of the things I wanted to try and put out there is the idea that regardless of which way you come down on would you sign the prescription, trying to ascertain what the patient's concerns are, trying to address them in the best way you know how, in palliative care, all that should be independent. Then you bring up another set of questions, which is really important and we don't really talk about much, which is the logistics, particularly in any institution you practice in, unless you're in a solo or small group practice where all your colleagues think the same, institutional policies really come into play. And the logistics of how you actually prescribe, what you prescribe, what doses, what pharmacies will fill some of these prescriptions, what if the patient is of sound mind but not of sound body and can't go down to the pharmacy herself? Who can pick it up? If it's in an institution, if someone's in a nursing home, will the nursing home stock the drugs you want to prescribe or even allow the practice to take place? So I think all those are important, pragmatic, practical issues. But I think, I guess the question I would come down to is, should you not get the patient interested in a topic that just won't happen because of the institutional constraints? Or, at least for some patients in a nursing home, could friends or family be mobilized to help?
Yeah.
But for example, I don't know if you all are, I know Alex and Eric, you're at the VA. I don't know if you are as well. But
me too, yeah.
Yeah, so so if it's the VA nursing home, I'm sure they have policies, and they may be national policies.
Yeah, with you can't use federal funds for physician-assisted suicide or euthanasia. So there's a congressional law that we can't actually bypass. But it doesn't mean that we can't talk to our patients, explore their wishes around physician-assisted dying, or connect them to potentially other resources without actually making referral. We can't make a referral, but we can educate.
You're forbidden from making a referral.
We're forbidden from using any federal funds and making formal referrals.
But we can give them information
and educate.
Yeah.
But this now gets down to nitty gritty. Are you allowed to say, here's the state website that explains all this?
That's an education. I would say yes. Like we're educating. We're not using federal funds to help people with the process, but we're educating them just like we would educate people on any medical condition or option.
Could you give them of advocates?
Yeah, so this is great, Bernie, because it's not like I'm on a national podcast that I'm going to get in trouble for talking about. I would say, again, anything that has to do with just around education, and as long as I am not sending them out to another physician who would prescribe it, that I feel very comfortable actually giving them resources around our state that they can connect to. Where you draw that line, I think it's that, we have we have clear kind of guidance on what we can do, can't do, again, with federal funds.
Yeah.
Where you draw that line of this is what I can do or can't do within a system like the VA where we can't do it, it's gray, right? So, but I feel for me and teaching others that it's really important not just to say, sorry, we don't do physician-aided dying, talk to somebody else. But to be very clear is, thank you for bringing this up. I'd really like to know, like, how did you start thinking about this? Where is this coming from? Why now? All these great questions, like what you and Lynn were talking about, inquiry, exploring, and then potentially addressing some of the issues that come up, whether it be around loss of control or depression or pain.
Which is a point that you bring up, Ernie, in your article in a couple of different areas. First, at the time of the initial question and exploring, you highly recommend making sure that you're treating all reversible sources of suffering, including comprehensive palliative care, noting that 46% of patients who have requested physician aid in dying change their minds. And then second, after somebody's written the prescription, that doesn't mean you stop treating sources of suffering and you stop, but in fact that you try to help this person find other reasons to live, and that many patients who obtain the prescription do not actually use it.
Right. That's right. So I think, and what I tried to say, and maybe it's worth repeating, even physicians who are morally opposed to, let's call it aid in dying, that's what the California law calls it. My argument is they should do that exploration, talking to people and really doing the most intense, successful palliative care they can, even though they and the patient know that there's a real difference of opinion with regard to the aid in dying. If I can double back, is that okay to go back
to
the issue that Eric and Lynn, you were talking about? So I don't want to make this a VA-centric, or certainly not put either of you on the spot, that I think in any institution, institutional policies may or may not constrain what physicians can do or feel comfortable doing. And Eric, you brought out that between what you're expressly told not to do and what you're expressly told that this is okay, there's a gray zone. And where in that gray zone will you be? I think it's really important for each of us to think that through, so that hospices have different policies regarding participation in aid in dying. So do institutions like UCSF or a hospital or a clinic that you would work in. So I think that it's important to sort of think this through. And I think in a lot of other contexts, we are not shy about referring people outside the system. So that, my practice is at UCSF. I, for a lot of reasons, tend to refer everyone to UCSF specialists. But if that's not working out, I will, and particularly if the patient expresses real unhappiness with the way a couple of referrals have gone, I will refer outside the system and say, well, I don't know what your insurance covers. I don't know those people as well. There's a little problem getting the records back and forth, but either it's closer to your home or they can give you a different opinion. So I think feeling comfortable saying the way we do it within our system is not necessarily the only way to do it. And for a given patient, they may want to at least think about, if they want to, the option of going outside the system.
I wanted to come back to a topic that you raised before about how the way you go about prescribing may differ within health systems and what you prescribe in formulations, if you're allowed to within that system. And as you note in here, barbiturates are one of the mainstays of physician aid in dying, and they've become really difficult to obtain, in some cases prohibitively expensive.
Absolutely.
And my understanding is that those who prescribe these medications frequently, the physician aid in dying medicines frequently, are actually, in some ways, they're trying to come up with creative new uses of existing medications to help their patients die quickly and without suffering. And it raises, for me, I wonder if you see some issues here, sort of the clinical and research ethics interface. I worry that there is very little to no oversight over these practitioners who are trying new formulations with patients. If we had, say, a cancer trial with some new drug, we would be up in arms if there was no oversight about was informed consent obtained. How much did they actually understand about this new treatment that you're trying and the potential risks and side effects, etc. And on the other hand, I also feel for those providers, because there is no mechanism to support research in this area. There is no mechanism to provide oversight that I'm aware of, and maybe you're aware of mechanisms, to provide a research infrastructure for these practitioners.
Great question. So let me try and distinguish between oversight and evidence. If you start with the assumption that barbiturates are maybe prohibitively expensive and very hard to get.
And wait, before we talk about prohibitively expensive, we're looking at $5,000 to $6,000. Is that about right?
Yeah.
So like 3 days in the ICU. Right. 2 days.
It comes out of it.
Right, but they're paying for this out of their out of pocket, right? Out of pocket costs. They're not paying for that ICU stay in almost all cases.
So there's actually not very much evidence on the older regimens that included barbiturates, and it's the Dutch who have done this. I mean, they've collected the best evidence on what are the adverse effects, how often does it work, and just parenthetically, one of the main reasons that physician-assisted suicide is not that common in the Netherlands, although it's legal. They use active euthanasia because they've had documentation of really disturbing adverse events from oral ingestion of medicines. So there are people who have been trying to devise regimens that are effective, that are tolerated, that are affordable, and presumably are safe. So it's an evidence issue. And I would differ a little with you, Alex, in that I'm not sure it's actual research, formal research that needs IRB approval and the like, but it's really practice, innovative practice. But there needs to be a systematic collection of what works, what doesn't, what happened. So I think what I would like to see is the doctors who are doing this a lot, and hats off to those who do it. It's very hard work. It's emotionally grueling. It's time consuming. Mm-hmm. My impression is that patients and families really appreciate what they do, that they keep a registry of what was prescribed, how it worked, any adverse effects, so that people can later on say, well, in a consecutive series of people using regimen X, this is what happened, and if it gets modified to Y, the regimen Y, this is what happened. I think the idea that things are intuitively going to work is good, but you need to see in practice. Things like, can people take all the pills? Will they keep them all down? Mm-hmm. Mm-hmm. Those are things that are real practical.
Mm-hmm. And there are some people who have terminal illnesses that will eventually end their lives, who do not fit into this physician aid in dying. For example, I think of people who have amyotrophic lateral sclerosis, right? ALS and a motor neuron disease, who will not be able to take the pill themselves because they are not physically able to do it, though they are of sound mind.
Or anybody with dementia who may not have capacity.
Right, and those cognitively not able.
I was going to give an example. I spoke at an Alzheimer's Association conference last year, and I was asked to sit on a panel there and talk about physician aid in dying. And a few months ahead, I said, well, what's the point? In this group, nobody here can access it. And this was a community-facing conference, so lots of caregivers and family members. And I have never sat on a panel with such anger and emotion at the idea that people couldn't access this on behalf of their loved ones.
Yeah, right.
It's pretty fascinating.
Yeah, I mean, the laws in California, Oregon, and the other 7 states and the District of Columbia are pretty narrow. It's terminal patients who are competent, not depressed, all that. But if you allow it for those cases, you brought up examples where logically it makes sense to extend it. So the person with ALS, who is mentally clear but physically unable to ingest the medicine, it seems to me that logically that just doesn't seem to be either consistent or fair. And you can certainly think of ways of devising robotic assistance to place the pill in someone's mouth on a voice command or something. But it seems like a lot of trouble, for the same effect.
Because we're kind of skirting around this physician aid in dying versus euthanasia issue, right?
So the ALS example, I would say it's still done at the command or voluntary decision by the patient. They are saying, the time has come, I want someone to put the pill in my mouth or put it in my feeding tube.
Yeah.
The Alzheimer's is different because they're presuming the patient is no longer saying, this is exactly the situation I didn't want to be in. Now's the time to stop. You've all come and said goodbye. I love you. Thank you. So it's someone else saying, this is what the patient would have wanted in this situation. That one step removed from the direct request or decision by the patient leaves it a little bit shakier, but logically I can see why people in that audience on their panel at that meeting when we're saying, this doesn't make any sense. This is exactly, by the time she is sick enough to be in the position that she dreaded, you're saying that she can't take the medicine. We can't administer the medicine.
Yes, and the other thing I was thinking about in terms of the ALS example, and actually in general, correct me if I'm wrong, but sort of once people obtain a prescription, it's there in their home. And they may be in a hospice agency or have some sort of institutional support, but they may not. And so we don't exactly always know how this ends up being administered in the moment.
No, we don't.
Yeah.
We don't. And frankly, that's one reason some have suggested that a physician or a hospice nurse should be present. There are a whole lot of reasons, but one is to make sure there is, at least in states like California, that's a voluntary choice, not someone else administering. But and if it were ever to get to the point, I mean, in the Netherlands, doctors make house calls to carry out either physician-assisted suicide or active euthanasia, and they, it's done by GPs usually, not necessarily by specialists, and they make it part of their job, and it does give some assurance that what was done was ethically appropriate. Although then there are also some problems with what actually was done in some cases.
So Bernie, last question. Yeah. Do you have guidance for clinicians who are listening right now? Maybe 3 things that we should be actively thinking about or doing to prepare us for these ethical dilemmas around physician aid in dying?
Let me try. So first is, to the extent possible, treat this like any other new intervention that you're likely to see in practice. Anticipate what might happen, think about it, try and read about it to the extent you can, talk to your colleagues about it who have maybe had some experience. Because I think more than kind of a new device or a new medication, it's important to sort of think this through in advance, because a couple of you had said when something comes up, you can almost feel like a clutch. What's going on here? What am I going to do? So I think that's important. Okay, so my second point is This is hard. It should be hard. And I think we all need to appreciate that. For all the reasons we've talked about, it's complicated. There's a lot of uncertainty. There's a lot of individualization. And I think you have to be willing to say this is going to take time, emotional energy, and a lot of sort of digging into yourself to say, how much time am I willing to spend on this? And what do I ultimately feel comfortable doing? And where would I draw the line saying, I'll support my patient up to this, but not further than that? And third, I guess, is a corollary almost of two. Talk to people about this. I mean, your partner, your spouse, your practice partners. I mean, it's really important that you not think that you're the only one going through this, or you have to kind of work this all out yourself, because the people I've talked to in practice who have faced this and tended to face it alone, because if you're in outside an institution, the whole pace of things is different. It's really grueling on people, and it's almost like, I guess, what's the hardest emotional subspecialty? Maybe pediatric oncology, that you need to be able to kind of re-equilibrate. But part of that is patients or families will tell you, we so appreciate your talking about this. You're spending the time. You're taking this seriously. You're engaging on a not just no, I won't, or yes, I will, but really we could see you trying your hardest. That's so important to families, to patients. And that sort of is the compensation for all the hard work and energy we put in. I think the other thing I wanted to say is that you want to try and apply the same critical thinking and evidence-based medicine skills, and to admit when we really don't know. And I would always say to people, every medicine has its adverse effects, and we don't know what all of them are. This may not work. There may be side effects. I've had people say they want to be in charge of how and when they die. And I feel I need to say we can't guarantee that, because we can't guarantee anything in medicine.
Well, it's interesting, though. It feels like this is even more of a black box, because it's kind of hidden from sight. At least we have people, we can see what's happening after insulin. We have people researching that. But this is doctors are often not there. It happens at people's homes, and there's very little follow-up.
Yeah. Well, and I think that's right. And I think I'm willing to say just a consecutive case series would be useful with standardized information on each case.
Yeah.
There's some of that's done in the state of Oregon and Washington have the best reports, annual reports. I mean, they'll talk about, adverse effects, but they don't specify what the regimen was.
Yeah.
And so you can't crosswalk it to drugs and dosages, which of course doesn't help.
No.
Well, Bernie, I really want to thank you for joining us today.
Thank you so much, Bernie.
Yeah.
Thank you.
Thank you for inviting me. Great questions. I enjoyed the back and forth.
Incredibly thoughtful responses.
Incredibly thoughtful.
I always learn a ton just listening to you.
I know. I always learn so much.
Before we end, Alex, how about end us on a high note with maybe a little bit more of the Beatles?
Another verse of Help. And now my life is changing oh so many ways. My independence seems to vanish in the haze. But every now and then I feel so insecure. I know that I just need you like I've never done before. Help me if you can, I'm feeling down. And I do appreciate your being round. Help me get my feet back on the ground. Won't you please, please help me?
Well, I want to thank all of our listeners, too, for joining us on this GeriPal podcast. We look forward to our next podcast next week.
Thanks, Bernie.
Thanks,
Thank you.
Alex and Eric and Lynn. It was a pleasure.